cells and try to regulate them. So this is our system. And we look at the heart and we say, first of all, what is the chronicity? Because when we look up the drugs, it'll talk like this to us. You know, it affects the chronicity. Well, that's the rate, right? The chronicity is the rate. And the rate is normally regulated through our vagus nerve, nerve number 10, to the SA node in the right atrium. And the vagal reflex keeps the heart beating slowly and normally. Okay, so that's part of our system that we don't even notice. The baroreceptors up in the aortic arch and in the carotid bodies, they're going to sense any decrease in pressure, and they're going to send out a reflux to the adrenal gland, which will send out epinephrine, norepinephrine, and speed the heart back up. And so all of that's taking place as we sit here today, routinely for us. Now the rhythm will either be regular rhythm when we take the pulse, so we have the time, and then we have the character of the rhythm. It'll be regular or it'll be irregular. Now, these PVCs, or a break in a general rhythm, which is longer than the normal pause, and then a resumption of regular, they're pretty common. They're pretty common. They're produced by smoking or when we're fatigued, we're under stress. If we're taking medications, we'll see more PVCs. If we're drinking more alcohol, we'll show PVCs. And if we have a damaged myocardium. When you find a strong and a weak pulse, we call it pulsus alterans, and it's strong one beat and then real thready. Strong one beat, real thready. And that's seen in severe ventricular failure. So many of our geriatric patients that are suffering from heart problems, they come in with the oxygen on now. If we take their pulse, we'll see the strong and weak, strong and weak. Their heart is very damaged. If we have severe arterial high blood pressure, we'll see this. These are probably not good patients to treat when the dentist isn't physically present. So, when we remember this rhythm, we have these little waves. We can be able to see my laser on here. Yeah, I'm sorry, I'm blinding you. We have our P wave, and the P wave is this small wave, and it starts, and that's the contraction of the atria. And then we have our QRS complex, which is the tall one, QRS. And that's a narrow wave, and it is the beat going through the ventricle in the ventricular contraction. So we always remember that the smaller one is the smaller chambers of the heart, the atria. And the bigger one, the crescendo effect, is the larger chamber of the heart, the ventricle. And it crescendos to push out throughout the entire body. And then we have a small wave after the QRS complex, and that's the T wave. And the T wave is the repolarization of the ventricle. And they should be lined up all in a row with a regular chronicity. Regular height, so that they're all about the same level, and regular chronicity. That's our ASA1 heart, okay? Perfect. There's nothing wrong with that heart. Now, occasionally, even a great heart is under some stress. And we get what we call a PVC. And that, we have the regular chronicity, and then all of a sudden there's ectopic beat. That's called a PVC, and every once in a while you'll feel your own heart skip a beat a little bit. If you've had too much coffee, it almost kind of frightens you a little bit. You get a little PVC. With that premature ventricular contraction, most of them create absolutely no problems, but know that they're there. So if you're trying to time a pulse and you're feeling every once in a while one of those, you might suspect your patient's under a little more stress about this appointment than is originally thought. And so you might want to do a little bit of talking and asking them about where they are. Now, the quality of the pulse is also measured by whether it's severe and bounding or weak and thready. So if we have someone very frail and their heart's not working well, their pulse can feel weak and sweaty. However, if we have someone very anxious and we're worried about them because the blood pressure is very high and we take the pulse and it's almost pushing our fingers away from the radial pulse, one would say that is full and bounding, and that is someone that would be set up for a stroke. So, of course, we would maybe want to defer treatment for that day, anything elective, get the blood pressure under control, get the pulse under control. Now, how do we measure? Oh, I'm doing my laser. Let's get back to that. Now, how do we measure the heart rate? Well, we count the beats in a minimum of 30 seconds, and we multiply by 2. The heart rate that's slow is bradycardia, or less than 60. Heart rate that's fast is tachycardia, greater than 100. An increase in rate with inspiration, when we stand up or when we breathe deep, and a decrease in rate with expiration is a sinus arrhythmia. It's frequent. It's seen a lot in adolescents, and it's absolutely harmless, so we don't worry about that. Then when we look up our drugs, they may tell us about the type of effect they have on the heart, the inotropic effect. And this is the force of contraction. Inotropic means how hard does the heart pump. If you have a positive inotropic effect, we would see that in epinephrine or digitalis, meaning if someone is on digitalis, they have a problem with the heart muscle itself. This is not an ASA1 patient and should be treated a little bit more carefully. Calcium blockers, if we looked up nifedipine, it would say it has a negative inotropic effect, meaning it has a negative force of the heart, and it has a negative chronotopic. So if we took the pulse of someone on a calcium channel blocker, we would anticipate that it would be slowed down chemically. It's my magnetic personality. The other thing we have to think about is the arterioles when we're looking at our blood pressure and what regulates that. And in addition to the force and rate of contraction of the heart, that's part of it, the blood pressure is regulated autonomically through the arterioles. Remember that all cells have like a little key lock on them, right? Little key lock. And chemicals or natural chemical mediators within our body systems fit into the key lock. Once the key is turned with the mediator or the drug, the cell goes about its business and it's incorporated. Now, contraction of the arterioles is an alpha receptor, and dilation of the arterioles is a beta-2 receptor. Okay? And the effect of adrenaline, or adrenergic stimulation, adrenaline, is going to be determined by the affinity of the receptor. So the affinity for epinephrine is higher for beta-2. So initially, when a lot of adrenaline is pumped into our system, we're going to get a vasodilatation. But at higher concentrations or more sustained concentrations, the alpha receptors will be filled and we'll get a reflex arterial constriction. So someone under long-term stress is going to see a rise in their blood pressure. Now, where are these receptors located? Well, in the heart, we have beta-1 receptors. So when adrenaline affects the heart, it speeds it up. It speeds up the force as well as the amount of the speed, the rate, force and rate, it'll speed it up. In adipose tissue, we have beta-1 and this special new receptor called beta-3. They're thinking that's related to our obesity problem. In the vascular smooth muscles, we have the beta-2s, which cause the vasodilatation, and the alpha. And in the airway, we have the beta-2 receptor. So to evaluate the effect of endogenous, released by the body, or exogenous, injected or ingested, one only needs to look at the receptor itself, and the drug is the key to fit the receptor, and the cell will open to fuel the response. So, if we were taking a beta blocker, it would reduce blood pressure. Now, a non-selective beta blocker would decrease the heart rate and dilate the bronchial tree. A selective one would only affect the beta-2 receptor and dilate just the bronchial tree. And we'll talk about that a little bit in the future here this morning when we talk about asthma and drugs we use and why. The respiratory system is the component parts of the oropharyngeal airway, which we're very familiar with, and the tracheobronchial tree and the alveoli. The diaphragm, again, innervated by the vagus nerve. So breathing is on the same course as the heart. And the carotid bodies, the ones up in the carotid, sense the arterial O2. The CO2 receptors in the medulla are the last final protective drive for respiration. So even if we had a severing here, we would still have a drive in our brain that keeps us breathing. So people that are paralyzed from the neck down can still breathe autonomously. The metabolic system is regulated by the endocrine system through the liver, kidney, and pancreas, and it controls the acid-base balance as well as the cellular metabolism. And the last system that is important in emergencies is our nervous system. We have the central nervous system, which consists of the brain and spinal cord, the peripheral nervous system, which is our reflex actions from the spinal cord, and the adrenergic nervous system, which is mediated through the adrenal medulla, and it is called the autonomic nervous system. And that's what regulates our heart, our blood pressure, and our metabolism. Now, when one of these symptoms fail, a plan needs to be implemented to restore stability as soon as possible. The Institute of Medical Preparedness, which is a great source to get more information, says that the office offering dental hygiene services under general supervision should have a set of supplemental algorithms for circumstances specialized for when the dentist is not physically on the presence. Oftentimes, the little algorithms that are printed in our manual procedures at our offices are there for the whole team. You know, the receptionist is going to call the EMS. The assistant is going to go get the oxygen in the medical kit. The doctor is going to come in and do the CPR, and the hygienist is going to assist. Well, if all those people are not there, very often when we're practicing under general supervision, it may just be us and the receptionist. So you need a separate algorithm for what's happening because you're going to be the person that has to be in charge of the patient, and you need to make sure that that's written. Now, as Goldberger, and one of the first to talk about medical emergencies in the dental office, said, when you prepare for an emergency, the emergency isn't really existing. The ultimate aim is the management of any emergency is the preservation of life. Okay? You're going to try and save this person's life. And so with that said, one of the requirements of the Ohio State Dental Board is that the dental hygienist complies with the written protocols established for emergencies by the dentist. So if you're practicing when the dentist is not physically present, you need to make sure of what the written protocols are, because if you operate outside of that realm, you may be operating outside of the law. Now, the Institute of Medical Preparedness says that we should have an algorithm for every one of these potential problems: syncope, cardiovascular disease, hypertension, hypotension, asthma, anaphylaxis, hyperventilation, allergic reaction, diabetes, seizures, sudden cardiac arrest, CVAs, foreign body obstruction, and local anesthetic toxicity. That's a pretty inclusive list. However, the requirements of the Ohio State Dental Board are not as inclusive. And so we're going to cover the ones today that the Ohio State Dental Board wants you to have, but know that there are other things that can happen and you should be prepared for those. So this is an introductory course, not an end-all course. Now, it's paramount that you keep your CPR certified at all times. Never let it expire, because that's a rule of the Ohio State Dental Board, that you must remain certified in CPR at all times. So always be checking, when is my thing due? All of us have had the experience where we've gotten close and we're thinking, oh my gosh, I'll have to go back and take that long course again. I've got to find a course, got to do this. You know, keep an eye on it, put it on your calendar, make sure you know when it's expiring so that you don't have to rush in to get it done. But we want to remain certified at all times, because that's a requirement as far as practicing when the dentist is not physically present. So when the State Dental Board would come in to check, you have to produce your CPR card in addition to the fact that you've taken a course like this, okay? Now, a simple plan. It can be as simple as this plan at your office as a sample. The specific task assignment for each member of the dental team, both full and part-time, an alternative or backup should be planned for the staff absent. So say the dentist is going to be away from the office for 1 week. And what they've decided is the receptionist will work Monday and Thursday with the hygienist, and on Tuesday and Friday, the assistant will work with the hygienist. You have to all be on the same page, who's doing what when, because you can't just say the receptionist will be in charge of calling 911 when the assistant doesn't know how to retrieve the number. Everybody has to have done some practice drills here, and practice drills with when the dentist is present and when you're supervising. You want general instructions on calling the emergency services, including the address and best point of entry for the office, right? So if you're like located in an interior group, you need to have address there. You know, it's a nice thing to Google map those things and then have those by your office right under emergency, and here's the directions, and let me read them off to you, because in an emergency we get very confused. Is it south or west? Is it right or left? What's the name of that road? You know, keep those little Google things right by your phone. And a general view of CPR guidelines, including airway management. Number 1, airway management and patient positioning. Now, when we talk about patient positioning, Trendelenburg is head down. Semi-Fowler's is kind of a 45-degree, and supine is how we normally treat our patients, okay? But when you're reading these medical dental emergencies books, one thing you'll notice is they'll tell you to position the patient in this Fowler's or semi-Fowler's, and you're thinking, what's that, you know? But that's like a 45-degree. Trendelenburg is head down, okay? Now, the Trendelenburg, if you had a very heavy patient or a pregnant patient, that could put more weight on the visceral organs and actually harm you. So you have to use discretion. You have to think a little bit. We want to provide a safe environment. We want to clear any materials from the airway and the surgical operatory that could hurt the patient. We want to place the patient on a backboard or a hard surface to do CPR. So if you have a patient that you need to do CPR on and you're going to have to assist them to the ground, maybe it would be better to do that prior to them going completely unconscious, because you're not going to have a lot of staff members to help you move that patient to do your CPR. So either find whether in your office you have a backboard, you can slip under them, but you know, dead weight is hard to turn. So you want to make sure that you have the ability to do CPR wherever you are, you know, so get them where they can be comfortably treated. You want to check the circulation. And no effective pulse, we're going to begin CPR. And remember, if there's no pulse, then we're only going to take 10 seconds to evaluate that. That's the new guidelines, right? No pulse. We're going to go with the CAB, circulation, airway, breathing. But for most dental emergencies, it would still be our ABCs, okay? ABCs, airway, breathing, circulation. But for no pulse, we go circulation, airway, breathing. We're going to use the automatic defibrillator if we have one. Not all offices have one. They're not required to have one. But if we have one, you have to make sure that you're going to use the automatic defibrillator, and you're going to record contemporaneously the vital signs. Now, if you're there alone with only one other staff member who's alerting the EMS, this is going to be a challenge for you because you might be doing CPR, but if the patient is still responsive, you want to be writing down, I had the blood pressure at 120/80 to start with in the day. When they went into this crisis, the blood pressure became 150/100. When they finally became unconscious, the blood pressure was 90 and I couldn't get the diastolic, and you want to have some timeline on what's happening at what time. And you're going to transport the patient for definitive care. Now remember, you're going to be the person that's going to follow up with the patient and with the emergency room physician, because the patient becomes your responsibility when the supervising dentist has entrusted this care to you. That's why the Ohio State Dental Board requires at least 3,000 hours and 2 years experience as a hygienist prior to saying you could recognize ill from not ill, emergency from something that they may recover. Okay? They're entrusting you to have this experience. Now, the supervising dentist also has a responsibility saying that he's evaluated the dental hygiene skills and he has deemed, he or she, the hygienist competent. And it's recorded on a form supplied by the board, and it has to be maintained at the facility where the hygienist is working. Now, if you're working in 2 different offices, you need 2 different certifying supervisors, and you need 2 different papers. And you can't be a fill-in unsupervised unless that particular dentist you have worked for in the past and has evaluated you. You can't just get called one morning and say, I want you to go up to Dr. Smith's office. The hygienist has called off and you can fill in if it's unsupervised, because if you've never worked for Dr. Smith and your papers aren't in Dr. Smith's office, you wouldn't be operating under the law. Okay, so that's a little different. Now, we've identified the patients that may be at risk. We've identified how to evaluate their medical history to see if there's changes. We've identified the systems that could fail us in an emergency, and now we're going to identify what equipment may be within the office that could help us in case one of these systems fails. Now, although the following emergency drugs and equipment may be at the office, it's important that you discuss with the supervising dentist what he or she expects from you. Okay, well, how much of this equipment are you to get out and use? Because if the algorithm that's printed in your office is not specific for you when you're practicing, and it's just an algorithm for, in general, if this happens to a patient, this is what we want you to do. Are you expected to use these drugs? What is the expectation? So you need to work that out with the supervising dentist on what you want to do or how much you want to do. The list of emergency medications is based on the nature of the practice and the medical health of the anticipated clientele and complexity of services. So an oral surgeon would have a much deeper breadth than I would have in my office. But I'm going very, very simple here with what we have in most offices. The most important piece of equipment in most dental offices is a portable oxygen unit. At minimum, it has to be an E-cylinder that would last 30 minutes. You have to have a nasal or a face mask in several sizes to use with it. And we need some kind of positive pressure bag. And all of us that are certified in CPR, it's a requirement for healthcare professionals that they are all trained in how to use a positive pressure bag. And I like a pulse oximeter. So this mobile unit is painted green, the universal color for oxygen, okay? And it's most important that you know how to work your oxygen delivery unit, where it's located, how to get it. Some of these are stored sometimes in the back of developing rooms with cloaks over them. We need to know who's retrieving that, how we're going to get it, where is it at, and how does it turn on? Is it full? Is someone checking it periodically to make sure that it has oxygen in it, okay? And it must be portable. Some of these new offices have central oxygen systems with nitrous and piped in, and they're lovely. But you have to have something portable, because if something happens as an emergency in the waiting room, there's no way to get the oxygen to the patient unless you have a portable unit, and it has to be on wheels. A backup system can be part of the nitrous tank, you know, as long as there's an extra backup of oxygen if you would need it. Now, oxygen is the most common emergency drug and can be used in almost every situation, except if somebody's already hyperventilating. You wouldn't want to add more. You can see whether the oxygen is working by placing this pulse oximeter on patients. Is everybody familiar with the pulse oximeter? These are very inexpensive. And you just put them on the patient's finger. They are battery operated. It has their pulse. So like in an emergency, you can get the pulse real quick by putting the pulse oximeter on. It'll tell you how the pulse is. And it tells you the oxygen saturation, which should be about 93 or above. And part of this course is the requirement that we talk about airway management. And so I'm going to take this break right now and bring it together with oxygen and talk about how we manage the airway. Because as I said, if there's no pulse, we're going to begin TAB. But I think our emphasis on taking that particular CPR course may confuse us. Most dental emergencies are airway emergencies. And so our oxygen and managing the airway is still primary on our head, even though we know if there's no pulse, we'll begin circulation. Okay? So I don't want to be confusing on that. And these slides I owe to Janet Bain. She was a doll and helped me with a little bit of the airway, and some other people, and so you'll see them referenced here. When we're going to open our airway and we're going to check the airway, we're going to check it because we've been in that airway, right? We've placed things like cotton rolls or gauze inside the mouth. And before we manage any airway, we have to make sure we've retrieved everything that we've placed in their mouth out of their mouth. And this becomes an issue if we're doing a sealant, dental sealant, and we haven't ligated our cotton rolls. It's slippery. The child's choking. If they're beginning to vomit. If they're beginning to vomit, they've got that airway totally open, and you can't get your cotton roll out. Ligate what you're putting in. You're going to open the airway by placing one hand on the victim's forehead and gently tilting the head back. You're going to remove any visible obstruction from the mouth, okay, including dislodged dentures, dislodged. If they're well-fitting, leave them in. It'll help you. And do not attempt any finger sweeps. We're not doing those anymore for anything, okay? Only if you can readily retrieve it. Don't do finger sweeps. So we're going to gently tilt. Notice that the hands are on the